Good afternoon, everyone. My name is Dr. Raquel Romero, and I want to be the facilitator for the session today. Thank you very much for making the time to be with us in the Comunidad Long COVID Eco Series. This project is a comprehensive long COVID care for underserved communities. This is an innovative delivery and dissemination model project, and also known as a Comunidad. At the UT Health San Antonio, our post-COVID-19 recovery clinic serves San Antonio and a broad and larger rural region in South Texas. And this community faces significant health disparities and barriers to care and misinformation about the long COVID. Um, and that remains widespread. To address those challenges, the Comunidad Project is a 5-year initiative funded by the Agency of Healthcare Research and Quality of Care, and the Comunidad Long COVID ECHO seeks to improve and expand long COVID care through innovative and sustainable models in our region and beyond. So if you are new to the ECHO platform, ECHO stands for Extension for Community Healthcare Outcomes, and it serves as a virtual and telementoring platform designed to create the connections between communities and subject matter experts. At each session, you're going to see the introduction, you're going to see didactics, and also a case presentation. So I'm encouraging you to join us in the discussion during the case presentation, and also think of the possibility of presenting a case in the future sessions. Contact us, and we want to help you to go through that. But because of those are real life cases that are presented, to ensure privacy, no personal information is allowed to disclose at any point in these sessions. So a few housekeeping reminders. I would like to ask you kindly, if you please add your name and your email and your affiliation in the chat. This is for our attendance records. If you have any issue with the connection, you can always contact our IT and you can send a message to that and using the chat. And remember that ECHO is all teach online environment, so we encourage you to participate in the discussion of these cases. So I invite you and encourage you to join us during that time. And if you are able and you feel comfortable, please join us by video. With that, I would like to move to the introduction of our team. And let me see, I would like to start with the organ of the squares. Dr. Broad, can you please introduce yourself as the leader specialist for the session today? Thank you so much.
Yeah, I'm Mike Broad. I'm a general internist and medical director of the post-COVID-19 program at UT Health Austin. Nice to join.
Thank you very much, our leader specialist for today. Dr. Tegranian, case presenting.
Hi, everybody. Roy Tegranian. I'm a psychologist on the long COVID clinic team here in UT Health San Antonio.
Thank you very much. Again, we're gonna presenting the case for today. And we have Dr. Capella as part of our hub team.
Hi everyone, Lisa Smith-Kilpla. I'm one of the principal investigators of the Comunidad grant.
Thank you very much. And today we have a didactic presenter, Dr. Chavez. Can you please unmute yourself and introduce? Thank you.
Hi, everyone. I'm Dr. Chavez. I am a PM&R physician with brain injury medicine subspecialty who sees patients in our long COVID clinic at UT.
Thank you so much for accepting and presenting the didactics for today. So just a final comment from my end. ECHO is all teach or learn environment. So I invite you and encourage you to participate in the discussion for today, and also think in the possibility of presenting a case in the future. So with no more from my end, I will leave this space to Dr. Chavez for the presentation. Dr. Chavez, on your time.
Okay, so we'll go ahead and get started. This is going to be just an overview to the anti-inflammatory rehabilitation framework that we use in our long COVID clinic. And so it'll just give a brief introduction into the importance of inflammation in long COVID and how we're approaching it so that you can get a good idea of what we're working on. So I have no disclosures or financial conflicts of interest. So when we're talking about long COVID, it's important to understand the proposed mechanism of inflammation and why we harp on inflammation in our clinic with our patients. So this is from the literature, and this is the proposed currently, from what we have so far, based on research, mechanisms of the inflammatory response that we see in long COVID. So there are two different proposed mechanisms. So the first one, and there may be a combination of both. The first one is you get this large surge of inflammation that happens during the acute illness, and then this inflammation persists. And so even after the virus clears the body, the state of inflammation sticks around. You get cytokine storms. And then potentially this inflammation is so severe that it may even predispose patients to meeting criteria for an autoimmune condition. And then you get your physiologic consequences that we see in long COVID. Depending on which organ system is most involved in the patient, you may say things like shortness of breath that's persisting, issues with palpitations, issues with neurologic function. The other proposed mechanism for inflammation is that there are some persistent viral reservoirs or persistent viral antigens that stick around in pockets throughout the body. And this in turn leads to ongoing activation of the immune system. And so when we see somebody in our long COVID clinic for the very first time, we're getting a history and physical exam, and we're hearing about what sorts of symptoms they got close to their COVID infection, what symptoms are still lingering. Based on their symptom presentation, we're going to be ordering the appropriate labs to evaluate for any organ system dysfunction. We may be ordering imaging that's needed for further evaluation. And then depending on the symptoms that are being experienced, we're also going to be engaging the appropriate specialists if they're needed. And so here's an example of what that might look like. So if we have a patient who comes in with chest pains described as neuropathic, they're experiencing some intermittent palpitations, then we may want to look at their labs, CMP, CBC, troponin, BNP. We may look at some inflammatory markers like ESR, CRP. And then imaging wise, we're going to be thinking about getting an EKG, a chest x-ray. We would also want to do a Holter monitor for 1 to 2 weeks to eval for any potential arrhythmias. And then when we're thinking about referrals, cardiology may have some additional tests that they'd want to run. We can send referrals over there so that if things like stress testing are needed or MRIs of the heart, they can consider ordering those things if additional workup is needed. And so when we first see a patient, it's very helpful if these screens have already been done. So if they've already been evaluated by a cardiologist, the workup has been completed, there's no concern for any issues as far as they can identify, and appropriate medication has been started if needed, then at this point, we're able to already start and initiate the rehabilitation steps. If additional screenings are needed, then this may delay the onset of formal therapies until we make sure that the involved organ systems are optimized so that they can get the best out of the rehabilitation program, and also so that we make sure that the rehabilitation program we're initiating is safe and most appropriate for the patient. And so because we talked about inflammation and how important this is in the presentation of long COVID, when we see patients for the first time, we are talking about all the different ways that we can decrease inflammation. So even if they still need to see a specialist before we're starting a formal therapy program, we can already work on getting them started on things that are going to decrease the level of inflammation in the body. So the first initial things that we share are lifestyle related changes. So these are the big five that we're talking about that can drive up inflammation. Inflammation, when it's driven up, whether it's in the setting of allergies, another respiratory virus infection, or any of these things, these five things that are presenting as issues for the patient, any of those things that drive up inflammation can make symptoms worse. So that's part of why this is a very important piece. So exercise, we're talking about physical activity as tolerated, and we'll get into depth about pacing. Pacing is very important when we're thinking about physical activity in this population. Sleep hygiene, keeping a regular bedtime, making sure they're sleeping for at least 7 hours per night. If they're getting chronically sleep deprived, then that can also drive up inflammation and make symptoms like brain fog and fatigue worse. Hydration is very important as well. Diet, we get some patients who have a lot of GI dysfunction or GI related symptoms. And so the diets that can be very helpful for our patients are things like the low histamine diet or the FODMAP diet, which are going to decrease those irritants for our patients. And then stress is also especially important for our patient population. They've been dealing with something that is still not fully understood. They may have struggled to get connected to the right specialists and are dealing with huge changes to their normal lifestyle. And so it's very important that we're also addressing stress as much as we can. And so this is kind of going into a little bit more detail as to what these things may look like for what we're addressing in the clinic. And so for exercise, depending on what level the patient's at, we may recommend formal rehabilitation program for them, which can involve physical therapy, occupational therapy, and speech therapy. This is largely focused on pacing strategies, so recognizing what they're able to do physically before they're going to get to a point where they crash and have this post-exertional malaise, and then are stuck in this phase for a couple of days until they're able to start feeling a little bit better. They're also focusing on building endurance. They deal with patients who have some autonomic dysfunction. Speech therapy can work on some cognitive strategies as well. And then we're also thinking about, based on the level that the patient is at, are we going to start with, do we need to start with the home-based setting? And we do have some home health care groups that are comfortable managing long COVID patients. Or are we able to have them in the outpatient setting where there may be some additional equipment, but also we have to think about the energy requirement that comes from going to the physical location and then getting back. And so depending on where they're at, we can order the most appropriate level of therapy for them. When we're thinking about sleep, if they have already tried the lifestyle changes and stress and anxiety are managed and they're still having trouble with sleep, if it's severe, and then we can consider doing other things like melatonin or trazodone so that we can at least get them started on getting some semi-restorative sleep while they're working on their recovery. And then when we're thinking about stress management, now we are so excited to have a psychologist on board. And so we are able to refer them to our long COVID psychologist, or if they have a preference out in the community, they can get connected with a psychologist who can help manage some of the symptoms and changes that they're dealing with. And then also initiating any medication management if we need to. And so this figure right here, we're not going to get into detail of it, but this is just to give you an example of the proposed mechanism for return to physical activity in long COVID. And so this follows a lot of the pacing strategies. This is a way to build up the endurance of our patients without triggering huge crashes. Initially, when they were doing some more traditional therapy methods, there's a lot of crashes and people just didn't, were feeling worse. And so we're not engaging in therapy as much, but now with some of these programs that are more tailored to this patient population, we're able to get some better results for them. And so the big P's that we talk about in the rehabilitation strategies: pacing, planning, prioritizing, and positioning. So these are all things that the therapists work with our patients on, so that they're able to get the most out of their day-to-day life and tasks. And then another therapy that we have is EECP. So EECP it has been used for circulatory related issues in CAD, in coronary artery disease. And so now there have been some studies looking at its use in long COVID patients. And because of the mechanism, again, talking about inflammation, this is the mechanism of EECP, and you can see the circled areas. And so we believe that it's improving oxygenation, and maybe improving some of the microvascular dysfunction in some of these patients, and reducing the pro-inflammatory cytokines. People who do these tasks may have a crash initially because it does simulate a lot of physical activity while the patient's lying down, getting these synchronized pulses to their heart rate. But after completing all of the sessions, and it is pretty intense, Monday through Friday, about an hour session for about 30 sessions. But once completed, do improve in their endurance. Some people will report improvement in headaches, and some of the other inflammatory driven symptoms as well. And then we also have some supplements that we may recommend. So some of these patients have Googled lots of things about long COVID, and they Google supplements and they get hundreds. So we try to tailor it based on what symptoms they're experiencing. If they're having joint-related pains and issues, then we may recommend curcumin, which is anti-inflammatory, but also helpful for joint pains. Vitamin C can be an immune system booster and also an anti-inflammatory. If there are some GI related symptoms, we can consider probiotic and prebiotics. And then for some of the more neurologic based symptoms like fatigue and brain fog, we can recommend N-acetylcysteine. And N-acetylcysteine actually has trials, randomized controlled trials that have been done that have shown some improvement in brain fog and fatigue. And then as far as medications go, we can consider a histamine blockade. So again, with inflammation being the name of the game, you think about histamine, which drives up inflammation. So we pair up an H1 blocker with an H2 blocker. They would take these medications scheduled for 2 months, and then we can evaluate where they're at, potentially wean off. And if this doesn't work, or some people may come in and have already tried this, then we can think about low-dose naltrexone. So low-dose naltrexone works as a partial opioid. So for people who have residual pains, muscle aches, headaches, joint pains, this may be a medication to consider. It gets compounded, so it has to go to a specialty pharmacy. We start at about 1.5 milligrams, and then we can increase to a maximum dose of 4.5 milligrams nightly. The other mechanism besides the partial opioid receptor is an anti-inflammatory. We're not sure how, but it's been used in patients who have Ehlers-Danlos syndrome or other types of inflammatory driven conditions as well. And then when we're thinking about rehabilitation, our goal is always for the patients to get back to work or get back to doing the most that they can. And so, especially if they're going to start a formal physical therapy program or be doing flow therapy, we'll consider the need for work accommodations and then, open conversation with the patient on our goal being that they return to work if time off is needed to focus on their recovery. Should the patient reach their maximum medical improvement and still be unable to work, then we can also assist with disability paperwork. And that'll complete our didactic session.
Thank you very much, Dr. Chavez, for this very informative presentation. It's very interesting, very important topic. I just want to take a second. I think I saw Dr. Monica Verduzco Gutierrez, part of our hub team. I just want to welcome her and see if she can introduce herself, I think.
Hello, thank you.
Thank you, Doctor. Thank you. I just want to introduce everyone in the hub team. Is there any question for Dr. Chavez in regards to this presentation? Any comment? I really like the 4 Ps.
I do see a question in the chat. What is a FODMAP diet? So the FODMAP diet is a diet that was created at Stanford for patients who had irritable bowel syndrome. And it looks at oligosaccharides and limiting some foods that have these pro-inflammatory oligosaccharides. And so it's, there's some things that are healthy that you wouldn't think, oh, this may irritate people, like watermelon, for example. And so it helps tease out some of those things that may be drivers of inflammation for people who have GI-related dysfunction or inflammation.
And how the patients take that diet? Do you have any experience in giving to them, and how did they be responding to this diet, Dr. Chan?
So I've had patients use that, and I've had patients use the low histamine diet and have pretty good control of some triggers. So they're mostly looking this up on their own. We just provide the name of the diets, and then we could probably do this. Is probably an area we could do better on with providing the actual documents that have the diets and the recommended foods to avoid.
Thank you very much. There is another question in the chat.
I see the question. Where do you see the role of cognitive testing? And do you feel the results may help structure the therapy or speech therapy able to do this? So speech therapy won't do the full neuropsych testing, but speech therapy does do an initial evaluation that involves some quicker cognitive screenings. But certainly the neuropsych test, which is like the 3 or 4 hour super in-depth test about memory and different ways the brain is functioning, can be helpful also. And actually, especially if we're going to be requesting some reasonable work accommodations, then the neuropsych test is really helpful to have, so that we have recommendations for work accommodations and formal documentation of neuropsych testing.
Thank you very much. Please keep adding those questions in the chat, or you can always unmute yourself and express and elaborate the question. Is there another question? Just want to give you another opportunity for questions. But during that presentation, you can always again put those questions in the chat, and you are encouraged to do so. But now we would like to move to the case presentation. Dr. Terrera has a case to present today. Thank you so much.
Sure. Hi, everybody. Just a friendly reminder, I'm a psychologist on the long COVID clinic here at UT Health San Antonio. I work pretty closely with Dr. Chavez. And one of the things that I think you're going to hear in my case presentation are some of the things that Dr. Chavez shared in her didactic, primarily around the anti-inflammatory lifestyle changes. You'll start to see some of those pop up here as I run through the case presentation. So the patient is a 45-year-old female. The patient received 1 dose of the Moderna vaccine. Made her sore, but no major complications. The patient contracted COVID twice, late 2020, early 2021. And then again, several months later, she contracted it. It was the first infection that she began to experience symptoms of long COVID, and the patient has been experiencing long COVID for approximately 6 years. Her marital status is divorced. Um, she has 2 children, ages 7 and 14. When she contracted long COVID, her children were 2 and 9 years old, and she shares custody with her ex-husband, joint custody 50-50. She works full time. She's in sales, and it's a pretty demanding job, and there are some financial factors that go into when the demands on her work increase versus when they decrease. And right now, we're kind of on an upward trajectory of the stress and pressure she feels from her job. Um, Her housing is unstable since her divorce 3 years ago. There's a, and I'll speak more about that in a minute here. She's also got a family history of hypertension and ADHD. As it relates to social support, the patient has a very supportive family and friends, which include her mother and father and 2 sisters and several close friends. Um, Financially, the patient is experiencing moderate to severe financial distress related to maintaining a home since her divorce and contracting long COVID. The patient physically is unable to attend to daily, weekly, or monthly, and even seasonal maintenance and upkeep. And as a result, she's seriously considering selling the home and moving in with family um, due to the required physical and financial upkeep and maintenance that she just can't manage anymore. She kind of views herself as a burden to her family. So having to move in with family is not something she wants to do, but it might be necessary for her to do. And that's psychologically affecting her, thinking that she's a burden to her family now. Patient denies substance use, current or a history of substance use. The history of mental health diagnoses. So the patient was diagnosed with ADHD, anxiety, and depression. This was prior to me treating her. The patient experiences anxiety her whole life and first noticed depression upon her high school graduation. And she reports moderate to severe episodic anxiety and depression because of what long COVID has done to her life. Her current diagnoses are ADHD and moderate episode of recurrent major depressive disorder. And she denies any SI, NSSI, or HI. Psychotropic medication, she's on Cymbalta, 90 milligrams daily, and Adderall, 30 milligrams daily. The physical symptoms is long COVID, autonomic dysfunction, POTS, post-viral fatigue syndrome, endometriosis, chronic migraine, and mast cell disorder. And the patient experiences headaches, frontal and temple region pounding, brain fog, insomnia, cognitive impairment, trouble with word recall or word finding, severe fatigue, post-exertional malaise, shortness of breath, and vertigo. She experiences dizziness and balance issues and walks with a cane since long COVID. Patient reports that she's adherent to medical treatment, however, is experiencing some mild to moderate treatment fatigue when having difficult days. Treatment fatigue is when people get tired of having to maintain the kind of medical protocols they have to be on, and it wears on them sometimes. So from a narrative perspective, so the patient reports feeling sad and angry that she's suffering from long COVID. Patient is grieving the life she had and the life she thought she was going to have, and what her illness has done to her children. So she's not been able to pick up or play with her 2-year-old when she first contracted long COVID. So you can imagine what that does to her connectedness with her youngest daughter. Patient reports that she was highly physically active and in good to great physical shape prior to long COVID, and is now sad and angry about the changes to her body and physical limitations. She perceived herself and kind of labeled herself as super mom prior to long COVID. And she had a full and happy life being a mother, being happily married, working full time, and being active and high energy. And she used to run a highly organized, clean, and beautiful home. Patient prided herself on being super mom prior to long COVID. She reports she is not the mom she wants to be now. That saddens and angers her, but she wants to be the best mom she can. She wants to be super mom again, the way she was prior to long COVID. Her husband divorced her 3 years ago due to her illness and how the illness changed her life. She's angry that she was abandoned by her husband, and she feels like she's going through this alone. The patient reports that her ex-husband gets to be the fun dad when the girls are with him, and that causes her to experience sadness and anger at him, her illness and what it's done to her life and her current life conditions. The patient has a hyper awareness to germs and is behaviorally diligent about letting germs into her home. I don't think it's at the level of OCD, but she's just hyper aware about it and just make sure that things are clean, shoes are off, clothes get washed regularly. Patient reports she's never fully rested and is often in an irritable mood. She's often laying in bed and is tired all the time. However, she has difficulty sleeping due to her anxiety. Patient reports distress about selling her children's childhood home, but she can no longer afford to keep it. Since the divorce, as I mentioned earlier, the home has become a financial and physical burden on her. We talked about feeling like a burden already. Patient reports that her home is disheveled and reports experiencing shame and anger about the clutter and disorganized conditions of her home. She reports that she does not have the physical energy to maintain the home's interior, and she's angry about this, as she was proud of how she used to manage her home previously. This last point is she reports that she's suppressed how she's felt for the last 5 to 6 years. And she mentions that intellectually seeing a psychologist will be helpful, but she's scared about letting it all out and what that might do to her. In either way, she's suffering, whether she sees a psychologist or not, but she sees the value in doing so. And then the goals that she set for therapy were to improve her sleep, to develop coping skills to address affective distress and reactivity, and improve her quality of life. And finally, she wants this to be a space where she can just vent and let out what she's been feeling and experiencing for the past 5 years. So as you can see, like Dr. Chavez said, the 5 important factors in managing anti-inflammatory lifestyle changes. She's having difficulty with sleep. Her diet is not good. She used to cook. Now she orders out just about every night because she just doesn't have the energy to cook. So you can imagine she's got kids, so they order, whatever generally the kids want, and kids don't generally eat a healthy diet. So fried foods, a lot of dairy, that kind of stuff. She's under a tremendous level of stress. So that's the second one of the lifestyle changes she's struggling with: financial stress, work stress. Well, I guess we're up to 3: diet, stress, and sleep. And she's unable to exercise. as well because of the physical limitations on her body. So she's got 4 of the 5 lifestyle changes that are challenges for her. So one of the things that I've noticed that Dr. Chavez does when I shadow her is she is performing at times role of therapist too, as she's trying to manage the physical conditions. The physicians wind up also playing some form of therapist as best they can. And the addition of mental health services to the long COVID clinic allows the physicians to primarily focus on the physical components and then refer patients to psychological services. So we provide comprehensive care to the patients. So that's the case presentation. And I think there are some questions that are on the screen right now. And I'll just go ahead and I guess I'll ask them. Is that what we're going to do here?
Yeah, we can
Great.
start with the first question if you like.
Okay.
Mhm.
Okay. So one of the things that we're doing is we're approaching psychological services through the lens of acceptance and commitment therapy for chronic illness and CBT for chronic illness. So the first question is, what other treatments do you think should be considered in the treatment of this patient besides CBT or ACT? I suppose we can even get to, medical, the medical side of things if we want to bring in the medical side.
If somebody from the hub would like to uh, give some answers or some comments in these regards, or somebody in the audience would like to give you, and also the questions are going to be in the chat in a second, just for us to kind of review the questions. But thank you so much, Dr. Tegarian, for this very interesting case and very detailed information in the context of what the situation of this patient. There's any comments from Dr. Brad? Yes.
Yeah. Roy, thank you so much for presenting this case. I think it resonates, and I've seen many patients like this. And I always just first, it sounds like you have done is try to normalize this of, I say it a little bit tongue in cheek, but I would argue that kind of anxiety, this hypersensitivity is part of the neuroinflammatory, hyperadrenergic and inflammatory state of the illness, and having long COVID is depressing. And so there is a grief and demoralization. I also think too, and you know this as a therapist better than I do, but they're especially high functioning, high performing people who have lost control tend to have the personality characteristics where they then, when they have lost control, try to control the things they can in their life. And that can also become self-defeating. And so a little bit of that commitment and acceptance really goes a long way, or mindfulness. And that always gets tough of when, I think it is appropriate to be wary of reinfection, triggers, pacing. But I've noticed that in some people, like when I put the visible armband and all of a sudden they're tracking their energy, then that becomes a fixation. And so also trying to work that through and how that could potentially be a double-edged coping mechanism to try to reframe it, always around their functional goals.
Yeah, well said, Dr. Broad. One of the challenges I think we face as care providers for patients suffering from long COVID is there's the physiological and the physical and the biological changes that are happening in the body, and then there's the psychological piece too. And I think treating the psychological components can help with symptom relief in some small way, right? There, as goes the body, so goes the mind. As goes the mind, so goes the body. So if we can help them psychologically help create a new identity with this chronic illness that they have to live with, and learn how to accept and still live a life of a values-driven life, but applying pacing and prioritization and helping them with these lifestyle changes. I think it could go a long way in helping patients with
And I'll
this
just
illness.
give some input too into the medication piece. Sometimes, by the time they've gotten to us, things are so severe that it's also necessitates some medication management. And one of the hardest pieces is emphasizing the importance of that inflammation, potentially driving a dysregulation of hormones in the brain. And so that's kind of, what I use to help explain why we may need to consider an antidepressant as part of the treatment plan, because sometimes they hear it and they think, oh, you just think this is psych related. And so it's important that they understand that inflammatory driven condition. And also, like, my background is brain injury medicine. And so, we're using these sometimes. This is a common manifestation that we see after traumatic brain injury or concussion, where there may be some dysregulation and inflammation in the brain.
Yeah, thank you. Thank you so much. Those are very, very important points. Dr. Kipal, I think I saw that you were on mute for a second. Yes, you have a comment?
Yeah, thank you. Well, now I have two because there's been an interesting discussion after my first one. With regards to the first piece of consideration of additional treatment elements, you talked a lot about how she was pretty self-defeating, and I wonder about your thoughts on the role of any kind of peer groups. So whether it be like a formal peer support group or just getting connected with some of the various individuals with lived experience communities that are out there virtually and or in person locally, for that sort of the not feeling quite so alone in the changes in function. And then based on some of the discussion sort of since then, second comment is just like really emphasizing the role that your work has in actually changing behaviors, right? So things like what Dr. Chavez mentioned, with sleep, with eating, with physical activity. One of the things psychologists are really effective at is behavior change and understanding the antecedents, consequences of behavior change, and what are the barriers for behavior change, and how to sort of induce longer term behavior change. And so that role in understanding what that might look like given the condition, and then how maybe changes in sleep are going to look, and what that might look like.
We thank you, Lisa. We did we did a sleep kind of analysis on what her sleep hygiene looks like, and she's engaging in highly cognitive activities. She watches really interesting cognitive programs, which is keeping her up until 1, 2 o'clock in the morning every night. And then she's got to get up early to care for her kids. So she's not getting adequate sleep, which is reinforcing the potential for inflammation. And as it relates to your suggestion around peer support groups or finding people with similar experiences, I think that's a great suggestion. One of the things that she's focusing on, she's isolating a lot. And part of what we need to help her do is find connectedness outside of her work and her daughters. That's primarily where she spends her time. So to normalize for her that there are other people suffering from this too and are still able to live, a values-driven life, I think could be really beneficial for her.
Very important point that the other people that are also suffering with some similar circumstances that can help, right? I think there's a comment also from Marisa. Would you like to unmute yourself and elaborate your comment? Because she said something like live experience communities.
Oh, I wanted to emphasize the importance of that and celebrate that. I love the lived experience role in evidence-based medicine, because that's certainly huge evidence of sharing that commonality and also believing our patients what they experience. But I also I got bumped off for a second and my previous comment before erased from my chat, but there is actual like dopaminergic neuronal senescence from COVID infection. So this is, I think, part and parcel to the mood changes and also why low dose naltrexone is so valuable in treatment. And so I've just really enjoyed Dr. Chavez's and Dr. Tergarian's talks today. Thank you.
Thank you very much for your comment. And we still have a few more minutes, but I would like to, if that's okay, to move to the third question. What obstacles or barriers to patients obtaining psychological service have you experienced or noticed in treating patients with long COVID? Anyone that would like to express some of those barriers or obstacles that you
I'll
have?
go ahead and share some of this. So I think that, one of the barriers has just been the access. And so in general, psychological services or treatments are just so hard to access with wait times and things like that. And so we didn't have a psychologist who was seeing patients with these unique experiences. And so I feel like it was also hard for some of our patients who were getting connected on, even if they did get connected on the outside, felt like they were still not really understood. And so that's one of the barriers that I was noticing. And then also, I mentioned this a little bit earlier, but also emphasizing that they are experiencing these symptoms, but also the importance of the psychological piece in their treatment and recovery. And so having patients understand that it is a part of the anti-inflammatory model that we're using, and not just a way to disregard some of their experiences or symptoms. I think that's been a challenging piece as well because of some of the experiences they may have had prior to getting to our clinic.
Thank you so much, Dr. Chavez. And to protect everyone's time, this is hard for me to say it, but we are in the time that we need to have those sessions. But I would like to ask Dr. Broad for the summary of the recommendations. But before, there is another comment here from Dr. Capella. It says social connection is such a fundamental part of the human experience. Yes, lovely that comment, Dr. Broad.
Yes, I think this is a tough one. It was an excellent conversation. Hopefully we gave you some more to think about. I know wasn't a lot of concrete, but I think certainly providing that validation, support, making sure the grief and acceptance is part of that, and building that relationship to potentially allow for pharmacologic options to augment the both physical and psychological aspect of the disease. And of course, yes, the social and more activating motivational behavioral change through social relationships can be really important too. So I know a lot, but hopefully that.
Thank you so much. And I hope Dr. Tegrayan, all the questions were answered. But as I always said, we invite you to present a follow-up of the case in future. So we will see how you manage this case, and we can learn from your experience. But thank you so much, Dr. Tegrayan, for presenting the case, Dr. Broad for being the lead specialist, Dr. Capella for your questions, IT, thank you, Kato, for your help, and Dr. Chavez, thank you so much for the didactics today. With that, I just want to let you know that in the chat, there is a survey for the certifications. If you please complete that. We have a deadline to do it. But I just would like to say again, thank you so much for this possibility, for this connection, for this time. ECHO is all learn on all teach environment. So with that, please think about the case that you can present in the future sessions. And I will see you in a month from now, April 2nd, it's in my notes. But thank you so much for your time, and you have a wonderful rest of the day. Enjoy this weather.
Thanks, everybody. Bye.